The following podcast is part of a certified educational activity titled Overcoming Challenges in the Treatment of Pediatric and Adult Patients with Uncontrolled Moderate to Severe Asthma, Comparing Approaches to the Use of Targeted Biologic Therapy with Experts Around the World. Access the entire activity and complete the post-test at peerview.com/AGP860. Downloadable slides and practice aids are also available.
Welcome to episode 4. In this episode, we'll be taking some questions from our peers about some of the most significant challenges in treating uncontrolled moderate to severe asthma. So Arzu, we start biologics and we really don't have a sense as to what criteria we should be using to determine whether a patient is responding or not responding. What's your approach to monitoring patients on biologic therapy? How long does it take for you to make an assessment for response or non-response? What do you do in that situation? How do you monitor? What do you look for? And what has to occur for you to decide that a patient isn't having the intended response?
It is a very frequently asked question, and it's not an easy task. But I may say that there isn't a universally accepted definition of a complete response or a single outcome. But we need to use a composite measures to evaluate the response to the biologic treatment. And as you know, Gina makes a very pragmatic recommendation for an initial therapeutic biologic trial for at least 4 months. Without before them, don't stop the biologic treatment. But you can also extend the trial of 6 or 12 months if you're not clear about the response of the patients at 4 months. So Gina recommends using the impact on exacerbation rates, systemic corticosteroid dose if the patient's on chronic OCS, and some validated symptom measures, ACQ or ACT, and quality of life. So I am also in my clinical practice using ACT and the ratio of the reduction in the exacerbations and the reductions of the systemic corticosteroid use. If I'm not clear, I continue the treatment to 6 months and re-evaluate again. Still not clear, extended to 1 year. And also, as Klaus has mentioned, comorbidities are also very important. So the assessment of response of non-asthma comorbidities are also important, like atopic dermatitis, urticaria, nasal polyposis, eosinophilic esophagitis. So we need a holistic approach to care here. So we need a composite measure. I am trying to join or merge these outcomes in order to evaluate my patients, but not before 4 months.
Thanks. I think those are really important. When we look at some of the clinical trials and the clinical experience, we see that many patients have a wonderful response and become exacerbation free. But it's also important to realize that the mean exacerbation reduction is about 50%, meaning that there are patients who are going to continue to have exacerbations, but could still very well be considered responders. A person who had 6 exacerbations in the prior year, who has 1 or 2 exacerbations in a year on a biologic, while not getting down to 0, is still having a very substantial response to that therapy. So I think it's important for us to not view a single exacerbation as a predictor of treatment non-response. I think that many patients get to that wonderful level of no exacerbations, but an exacerbation still is, to me, not indicative of non-response or failure. Would you agree with that?
Yeah, sure. We need composite measures.
We do. We need to take a more holistic view of the overall response, realizing that not everybody is going to have the ideal response in every domain or every aspect. So, Klaus, These are expensive injectable medications that we start with the intent of these being chronic long-term therapies. But most patients aren't really interested in lifelong prescription for any medication. And we're often faced with the question of, can we taper or reduce a biologic in patients who are doing well? How do you think through this situation, realizing that the data are relatively scarce for making an evidence-based decision here?
Well, I like this question, to be honest, because I think that's the question I've been asked. I get these questions from my patients, and my short answer to patients usually is, "You're doing well, not despite the fact that you have the drug, but because you have the drug." And that's how the discussion starts. But seriously, there is very little data about this. The only thing that has been studied systematically has been Bill Bussey's paper on people with anti-IgE that were tapered off or stopped treatment after 5 years of successful treatment. And the story was actually quite clear that a lot of individuals returned to having their symptoms of complaint when you stop it. So it's not a good advice to everyone. You get better if we stop it. There's one thing that I would want to tell our listeners and viewers, and that is, whatever you do, don't tinker around with making your own schemes of dosing. Don't extend the intervals. Don't change the dose. Stick with these drugs to the prescribed information how they should be used. And this is not an answer, could you do a little less? You either give the drug or you say you could live without it. I think for me, that's a rule. The second thing is, what I do, and I agree with Azur, that there should be a composite measure over a given period of time. And if someone has been successfully treated, after 1 year, we would debate what is remaining in his or her symptoms and whether we could actually sort of go without it. And that is an individual decision. I sometimes make an agreement with patients and they say, listen, you're so stable now, you were not very severe with your exacerbation first, there's nothing at hand, you reduced all your other medications. We could make a try to do this without for 3 months, but it would always be an individual part of this. Secondly, you said, and I agree with you, Len, that some people will have a 50% reduction of their exacerbations, see the studies, but they still have remaining problems. And that would be also an argument for me not to stop it, because you come to a compromise. There still is not 3 exacerbations, but 1. In this case, I would not advocate this. So with other words, it's a little bit between, the fingers. It's a little bit of assessing your patient. It's a little bit about a holistic measurement and not going on one parameter, such one biomarker, or only lung function, only exacerbations. And it is an agreement with these individuals that have the right to be treated optimally, but there's no guideline yet. But when you ask me, then, you're a pediatrician. I'm sure that caregivers that you have convinced that a biologic for their child would be a good option, they would ask you a lot about this as well. What do you tell the parents of your children that you care for?
It's a really common question, because in the management of children with asthma, we have to remember that there is an evolving natural history that is occurring with the disease. And we definitely see changes in disease activity and disease prevalence around the time of puberty. We see that boys have a tendency to improve, girls may have a tendency to stay the same or maybe become a little more severe. So I think we need to be cognizant that there is indeed an evolving natural history that's occurring while on therapy. And we need to think about, when we've achieved a sustained period of excellent control, no exacerbations, little to no symptom activity, to ask ourselves, is this disease really getting better on its own, or is the entire effect really a therapeutic effect of the medication? So in many cases, when we've seen sustained 1-2 years where the disease really seems to have gone totally quiet, we will think about either increasing the dosing interval or totally discontinuing the biologic, provided the patient is already on relatively low dose ICS background therapy. But we have, in children, this opportunity to let the disease run a course that may be different in more established adult disease. So I think there's a real important element of reconsidering the need for ongoing therapy in patients who are doing exquisitely well. So, Arzu, one of the other questions that often comes up is how to handle a situation where a patient could be on more than one biologic at the same time if the response to the first isn't sufficient. Said differently, you have a patient on a given biologic and they aren't meeting the goals of therapy or the expectations. Is there any role for doubling up with an agent of a different category, or should we be discontinuing and trying a biologic with a different mechanism of action prior to considering dual or multi biologics simultaneously?
It is possible, but as you have said, we don't have any clinical trials of safety or efficacy of the biologic combination therapy. We have some observational studies or case series with some reported successes, but we need clinical data for this. But I would like to emphasize or underline an important issue that we know that the most biologics have a long half life. If we do a direct switching without having a washout period, so the patient will be on the combination treatment, which is common in clinical settings, and that patient may be on dual therapy immediately after a switch. So after 6 or 12-month assessment to accurately assess the response to the new therapy is needed. But I would also like give the importance of the cost issue for the two or more than one biologics. We need data to recommend this.
We always have to prescribe medications in the context of a payer system. These biologics are on the expensive side of therapeutics that we have available for asthma. And we know that patients have varying insurance coverage, and insurers are variable in how they cover, reimburse, approve these medications. Do you have a sense as to how providers are navigating this complicated area? It's got to be, region specific. But Klaus, what's the experience in Germany?
Well, then I think that we all know insurance issues around treatments such as biologics. I think coverage is very different in terms of different parts of the world. So from a European perspective, most people are insured or everybody's insured, but the coverage in terms of what's included could be in discussion, and we all know that. So I think it's a relevant question for patient care. I can tell you what we've been doing and what we still do, and I think that is probably a workable program. When the first biologics came on the market, people were even more insecure how to handle this. So what we had local, if you want, networks that a practicing physician that doesn't come from a specialized center would actually have an indication for a patient, and he would ask a referral center that specializes on this. In this case, our place. I've seen people with severe asthma all my life, and so we had a 4I principle, if you want. And I said, Dr. X has made this indication. I do agree with this on the basis of this, that, and the other, and sort of give some arguments for that. And we asked together at the insurer, who found it much more difficult to actually sort of, whiz off what the primary care physician or the primary caring pulmonologist and the referral center would say. Then it worked out that insurers came back to us at some time and said, listen, we understand the system now, it's reliable, you don't have to do this anymore, we will agree with this. And basically, we did this with the Know Your Biologic in the same way. So what we offer in our network of our referral centers to our specialized center, we said, listen, in case of a question or in case of lack of an argument or in case of consideration that you're unsecure whether someone gets a biologic at all or whether if they should have a biologic, which one we should have, we have a larger panel of biomarkers, someone available. Not everybody can measure pheno and so on and so forth. So we come to if you want, an agreement with more than one site. And in my experience, that has helped the relation with the insurers because they understood that we understand their concerns. We give them arguments why we did this. And that to us at least has helped a lot. And it has helped the working in networks in the respective areas that sees these patients because they are pretty common. And if you accept that someone would say, you think he's a candidate for biologic, but have you thought of this, that, and the other? We set this in the program. I'm not sure that it even is asthma, or I'm not sure that the person takes his medication properly. I'm not sure that the drugs that he has so far are sufficient to make the case for a biologic. That has helped actually the debate around us. So that's what I would recommend. Strictly, not evidence-based, strictly based on my clinical experience, what has been working for many years in our neck of the woods. And I think that's probably something that you could think about and maybe you could copy.
Thanks. The sort of regional challenges with this, I think, are quite substantial. And certainly the American healthcare system has plenty of complexity in this area. And I can't say that I could give folks a foolproof strategy, but the one thing I would advocate to all providers is that we must be our patients' advocates. The insurers are unlikely to be exceptionally generous with these medications. It is our job to persuade, convince, and really pressure these payers to cover these life-altering and life-saving agents for our patients. And we need to be committed to doing this. We shouldn't take no for an answer. We should exhaust all appeal processes, write firm, convincing letters, do peer-to-peer phone consultations, and do what's necessary to get these agents into our patients because they really can alter their lives in very substantial ways. Thank you so much for joining us, and I hope you've found this activity to be useful as you continue to care for patients with moderate to severe asthma. And special thanks to our faculty members, Drs. Rabe and Jorgen Jolu, for being here and contributing your insights to these discussions. Have a wonderful day.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/AGP 860. This activity is supported by an educational grant from Sanofi and Regeneron Pharmaceuticals.